Dear friends, I am Dr. Shivakumar. I am bringing greetings from Apollo KH Hospital, Vellore. Here I am presenting a case of 55-year-old postmenopausal lady with persistent headache and vomiting of 10 days, which has been there for many years. The vomitus predominantly contains indigested food particles with significant loss of appetite and weight. That's a history of acid ingestion 25 years ago that was managed conservatively. Though she is thin built and general condition is fair, systemic examination is within normal limits. Abdominal examination, no significant mass lesion. Its clinical diagnosis of gastric outlet obstruction with secretase DU or acid ingestion induced pyloric stricture has been made. Upper GI endoscopy revealed there is a complete gastric outlet obstruction. Biopsy negative for malignancy. Contrast CT abdomen showed the overdistended stomach with the diffuse circumferential wall thickening at antropyloric region. So cardiac anesthetic evaluation done. She got admitted 3 days prior to surgery and she has been optimized for electrolyte imbalance. Here the plan is Lap TVGJ. This is my port position. So initial diagnostic laparoscopy has been done to make sure there is no other mass lesion inside the abdomen. There are few congenital adhesions to the abdominal wall noted. You can see the stomach is well distended. The initial dissection starts with approaching the crura for vagotomy. So the lesser sac is opened, right crush is being identified. So this is the hiatal dissection is being continued. You can able to see the right crest. So right vagus nerve is usually posterior in location. So the vagus nerve is identified. Around 1 centimeter chunk of nerve is being divided. Followed by identification of the left vagus nerve is being done. And as we know, left vagus is always anterior in location. So almost 1 centimeter trunk of the left vagus is being divided and sent first to pathological examination. Then comes the momentum around the greater curvature of the stomach is being divided and greater curvature of the stomach is being freed now. My camera is in supra-umbilical location and my right hand working port is in the left mid-clavicular line and left hand working port is in the right mid-clavicular line just below the costal module. I put one more port in the left lower abdomen for retraction where the vomit is being retracted by a staff. So mental lysis is being carried out. No need to do complete vomitectomy as we do in radical procedures. So for adequate exposure of the gastric wall has been done. Till that time, mental dissection is being carried out. Once adequate dissection has been done, the posterior wall of the stomach has been exposed adequately. Then going inferiorly to identify the DJ flexure. From that I am going to measure the jejunal limb. The transverse colon and mesocolon is being mobilized. That is the DJ flexure. From the DJ flexure, the jejunal limb is being identified. Here my plan is to do posterior isoperistaltic gastrojejunostomy. So the loop of jejunum is being identified. It is being freely coming to the stomach. So there was is going to be done between the posterior wall of the stomach and jejunal limb. That is the proximal limb. Initial fixation stitches between the jejunum and the posterior wall of the stomach is being taken with the help of 3 silk sutures that helps to hold the loop in position so that it won't fall away. Now I am making one more 10 mm working port in the right side of the abdomen between the previous left hand working port and the camera port. So then my camera has been shifted from the supraumbilical location to the right side of the abdomen, which is almost 4 to 5 centimeter lateral to the midline. So now the supraumbilical port becomes my right hand working port and my left hand working port which is in the left hypochondria. That's left costal margin, is my left hand working port. So in this way, since the camera has been located from suprapubic location, the right side of the abdomen, the orientation, everything is found to be very perfect for suturing, especially if you're planning for hand suturing. It's kind of like we are doing in open surgery, how the stomach is being oriented. Here the stomach is oriented so that excellent vision is there. You can able to do anastomosis clearly. Here my plan is to do hand-sewn gastrojejunal anastomosis in layers. Now I am just taking bites in the posteriormost layer between the jejunum and the wall of the stomach by using interrupted silk sutures. As we progress subsequently, we can just shift the traction so that the loop can be in alignment with the same, so subsequent bite will be easier to take. Using camera in supraumbilical location and proceeding with hands and choosing is a little difficult, so changing the location of the camera helps in better visualization of that area and better ergonomically better to suture. So that completes my posterior layer closure. Now I am making enterotomy in the jejunum with the monopolar hook. Then the enterotomy is being enlarged for making adequate anastomosis. Approximately 4 centimeter of the jejunal loop is being opened along the antemesenteric border. Then gastrotomy is being made in the posterior wall of the stomach. Once we are inside the stomach lumen, the wall of the stomach is being opened up for same length of 4 to 5 centimeters as I made it for the jejunum. Once the stomach and jejunum has been opened out completely, now I am going to make suturing. Here I am using 20 PDS suture. Initial corner stitch is being taken at the edges. So what procedure we follow in open surgery has been followed during laparoscopy also. That is, from out in and in out and out in and in out stitches are being taken at the corners. Once the corner stitches has been taken, then going to do classical gastrojejunal anastomosis. That is the actual third layer as we do in open surgery. Here I am going to do it in a continuous fashion, taken from the jejunal to gastric wall. Third layer of gastrojejunal anastomosis is being carried out in a continuous fashion here. As in open surgery, proper assistance is needed in laparoscopy also. Here my assistant is holding the sutures in place and retracting it so that I can able to make subsequent bites in a right manner. Almost going to complete the third layer of gastrojejunal anastomosis. Taking bites in the corner is the most important thing, as the chances of leakages are found to be high if you are not taking adequate sutures and you are not approximating adequately in the corners. So from in out from jejunum and out in on the gastric wall is being taken. Supposed to be my last stitch in the posterior wall. From inner aspect of the gastric wall, I am coming outside. It's the third layer of JJ. Now I'm just tracing the Rayleigh tube and placing the Rayleigh tube across the anastomotic site into the jejunal limb. This is just for the purpose of decompression at the GJ site for initial 24 to 48 hours. Now I am going to start the anterior layer anastomosis in a continuous fashion using same 20 PDS. Now I have taken a separate suture starting anteriorly in a continuous fashion. So continuous gastrojejunal anastomosis is being matured using 20 PDS. From serosa to mucosa and mucosa to serosa, the bites are taken. Very good assistance is really makes our job easier. So the correct amount of traction has to be given over the suture. If too much of traction is given, the sutures might give way or may cut through. If it is too less, then anastomosis will be a loose and chance of leakage is also more. So very good trained assistance will make our job easier, especially in minimal invasive procedures like these complex surgeries. Almost I am halfway through the anterior layer closure. This is the final part of the gastrojejunal anastomosis. Here you have to be very careful. So you have to identify each layer of the jejunum and stomach, and you shouldn't make it tight. So just make a loose sutures subsequently. Once you are in place, then you have to tighten the subsequent sutures so that approximations will be perfect. Almost we have come to the corner of the gastrojejunal anastomotic site. The sutures are being adjusted to make it tight. anastomosis is here. I'm now just going to make a knot to previously made suture along the third layer of the GJ. That will complete the gastrojejunal anastomosis. Additionally, gastrojejunal fixation stitches I am taking from the jejunum to the posterior wall of the stomach, so that the GJ stoma is well aligned and there won't be any narrowing stitch or kink over that area. So this is the final appearance of the gastrojejunal anastomosis. So this is the proximal limb of the jejunum from the DJ flexure. This is the anastomotic site. This is the distal jejunal limb. That is the alimentary limb. Finally, hemostasis has been checked completely. Then omentum has been used as a wrap to cover the anastomotic area as an additional protection. Finally, the ports are removed. Both the tendinum port site has been sutured.